introduce Dr. Mayor Hicks, recently joined Texas Oncology. So the first few slides will be an introduction to Texas Oncology so that all of you know what we can offer for you or your family members. Next slide, please. That's me. We can keep the next slide. So Texas Oncology is a community-based practice. When we mean community-based practice is that we are very close to you. So we have offices in most of Texas. You can see primarily. Well, you can see the stars. So most of the idea is that you can get access to cancer care that is close by. So you don't have to drive many hours away. Oh, unless you're like maybe in this area. Next slide. But yeah, most of the close to the cities we have access. So cancer, it's an unfortunate disease to have. Almost about 1.9 million cases happen in the U.S. and that can be from like very indolent type of cancers, to slow growing, to very deadly cancers. Almost 130,000 of these are expected to be diagnosed in Texas. 42,000 are estimated to die from the cancer. And Texas ranks third in the nation for most new cancer and third expected cancer deaths. So as you have heard in the news, on the everything like on the TV, cancer, it's very prevalent. The more we live, the more cancer will be, because like cancer is part of the aging process of the body. And before, when people will just like survive, I don't know, like in their 40s or 30s, cancer was not at that time very prevalent. But now that we're living into like 100 years old, 90 years old, that's when we are starting to see all those cancers coming up. Next slide, please. So within our group here in San Antonio, we do offer a lot of medical specialties from cancer perspective. We are 29 medical oncologists, 3 gynecological oncologists, 3 breast surgeons, 5 colorectal surgeons, 4 radiation oncologists, 1 thoracic surgeon, 1 hepatobiliary. This is a doctor that specializes only on the liver and the gallbladder and pancreas. And we have advanced care practitioners and 3 social workers. We are distributed among the main San Antonio metropolitan area with several office locations. I am from the medical office center, which is the largest one. We're kind of like we have like 12 oncologists and most of the gynecs are there. But we do have our other physicians that they go to the other satellite office as well. So why do we have so many doctors? Because cancer requires a multidisciplinary specialty group. You need to have several specialties to be able to treat it. So you have the medical oncologist, which plays the role of the primary doctor in cancer care. So he or she's the one that mostly decides whether what type of treatment you're gonna get, chemotherapy or not, or even from a screening perspective. We have the colorectal surgeons that they help us with most of our patients with colon cancer, because some of them require surgery. We have the radiation oncologists, because also for cancer, in addition to the three arms of treatment for cancer is the chemotherapy, surgery, and radiation therapy, and that's why we also have the radiation oncologist. So it's very important because each case is unique. So that's why we have to have all the doctors involved. And it's really convenient because we have them all in the office and we can just, the patients, I can talk to my colleague, or the patient can just in the same day see both doctors, for example. Okay, any questions at this moment? Okay, next slide. So as I mentioned before, we are community-based care. And why? Because as we say, like, for example, close to critical support for family and friends. We're close to you. You don't really have to, before Texas Oncology, cancer care was only provided at major medical centers. So a lot of the patients have to travel from far away to get all the treatment. That's no longer the case. Now there is a Texas Oncology close to everybody. We're a network of more than 500 physicians across the entire Texas area, and we have 55 comprehensive cancer centers providing most services under one roof. We also have these 210 locations. And then what we provide is all of us, we are board certified, and we provide a standard of care practice. And in addition to that, we also provide novel therapies from the research perspective, that we can have clinical trials involved if the patient is not able to get in for example, sometimes patients are not able to get what is considered standard of care, and sometimes we have clinical trials where they give access to the patients to more novel therapies. And that's also provided within the network. Next slide. So these are all some of the other services I already mentioned. In addition, so as a medical oncologist, I don't really I see cancer. However, I am also a blood specialist. So I do see what is called benign hematology. So we are the doctors that manage your anemias or clots, or you have like low platelets, or you have abnormal, like you went to the doctor and you see that in your CBC, your complete blood count, you see that, like, I don't know, the number is a little high or low. I am the one that normally sees what's the next step. And that's where I also get the referrals. Patients with, like for example, today, I saw a patient that she was anemic and she was menstruating. Most women tend to be anemic. They feel fatigue, they feel tired. Sometimes, most of the time, they need iron. So that's why, like, I also take the role of prescribing iron and see what's going to be the best step. So that's hematology. Medical oncology is primarily assessing the need for either chemotherapy or not chemotherapy. My responsibility as a medical oncologist is to decide for the patient whether chemotherapy it's indicated. So not everybody with cancer needs to have chemotherapy. However, there are some scenarios where I cannot give chemotherapy because my main decision making is balancing the risks and the benefits of giving the chemotherapy. Sometimes if I give the chemo, I can harm more the patient than not giving the chemo. That's a chemotherapy, blood, and more on marrow transplant. So that's primarily with a group in Methodist Hospital. Methodist Hospital has a transplant center here in the entire San Antonio area. And transplant is very important for patients with malignant hematology. So what is malignant hematology? Leukemias, lymphomas, multiple myelomas, and other bone marrow abnormalities. Diagnostic imaging, we provide diagnostic imaging in the center, CAT scans primarily, or x-rays. Hematology already mentioned, we have laboratory there, it's on site. Urology, some Texas oncology sites have urology. The ones here in our San Antonio area, we do not have a specific urologist, but your doctor will be more than happy to refer you to one of the one that he normally close works. Breast surgery, we have breast surgeries in the practice. Intervention radiology, this is primarily done in our affiliated sites, Strict or Baptist MNS. That's the other ones that we normally do. Radiation oncology is on site. Pediatric hematology oncology, here in the San Antonio area, it's primarily through the Methodist Hospital or through the University Health. Pharmacy, we do have a pharmacy on site. Neurological oncology in the San Antonio area, we don't have a neurological oncology. However, in our partner city in Austin, we have two physicians there. Gynecological, we have here. Research and clinical trials, we have it here as well. And proton therapy, that's done in Dallas because proton therapy is very novel and it requires a very expensive equipment. So it's not available in all sites. And sarcoma and orthopedics or oncology, that's depending on what type of sarcoma, it can be treated, but some of the time it's referred to a tertiary facility because it's very rare disease. Next slide. So this is just kind of like explain again the same multidisciplinary management of cancer. Basically, you have the physicians, you have the pharmacists, you have the social workers involved, the nurses, the medical assistants. Cancer care is very complex, requires a lot of support, a lot of services, and that's why most of the time is also very expensive to treat because the medications are very expensive. All the research that has to go into the development of these novel therapies, in addition to all of that. So that's just how you know. Next. What is a clinical trial? Do you any of you know what is a clinical trial? Yes, okay. So a clinical trial is a way of bringing novel therapies and trying to find new treatments for cancer. We always want to advance medicine and want to find the next cure and what it works best for our patients. So right now, few cancers are able to be cured, or some cancers that before there was no treatment, now we have pills. You just take like a little pill like a Tylenol. So that's where the clinical trials come into effect. We are trying to develop new medications, and the only way that we can know whether they're effective is by using them on people. Now, some patients tell me, doctor, is a clinical trial like if I am a guinea pig? I was like, well, Not really, because what happens is there are many phases of a clinical trial. Okay, clinical trials start from like phase 0. That's when like in the lab, in the bench, like in the bench work, they found a compound and they tried it in mice. That's phase 0. Normally, when we start taking testing in humans, is about phase 1 to phase 2. Phase 1 is when the medication we know that has been working on mice or in animals, and we have to try it in humans and see where it works. But we try it with a very limited number of humans. And most of the time is patients who, unfortunately, they don't have nothing else that is working. And they just have to try it because why not? To see why it doesn't work. So through one of our partners called Next Oncology, we're going to be able to offer phase 1 clinical trials. So that's phase 1. Phase 2 is when you try it in a small population, but you're expanding it more. So then you have, instead of like 15 people, now you have like 50 or 100 people. And then the phase 2 to phase 3 is pretty much where you are testing all over like the world, like in Mexico, in the US, Canada, and it's multi-center. And those are the ones that most of the time we do offer in the clinic, because those are the ones that we know that they're working. So the main goal of the phase 3 is to see whether it works or not, so that they can replace the other lines of therapy that we have. So in San Antonio, for example, we have more than 30 clinical trials, more than that. And in the medical center, that's where we have most of them. Now, as with a clinical trial, things to know is that so clinical trials, unfortunately, they have a specific criteria and exclusion criteria who can be in the clinical trial. So not everybody can be in a clinical trial. So most of the time, the medical oncologist is the one that makes the decision based on the treatment, whether they feel that a clinical trial would be best option for you or standard of care. Next slide. In addition to the other services that we provide, these are other ancillary services: dietary and nutritional counseling, financial counseling, social services, survivorship programs. Oops. Sorry for that. We also have volunteer programs, and also we have bilingual physicians like myself and other staff as well. Okay, and advanced care planning for patients who are with a terminal illness that they will die. So that's where we go into play. Next slide. Next slide. So this one. So this is the basically mentioning about the oncology care model. This is emphasized by the Centers for Medicare and Medicaid. Most of the time, what we offer for all of these patients is through education. Like as a medical oncologist myself, I try to educate my patients so that they understand what they have. Okay, so what type of cancer they have. They need to understand why are we treating the cancer and what is the rationale. So then with the education of the patients, they can also comment on their treatment choices. So it's not like I'm just saying, oh, you're going to get this, but I want the patient also to be involved in the decision-making process, so that you can understand the treatment plans and the test results. The other one will be maintaining health during treatment. As a medical oncologist, my main goal is to that, okay, yes, the patient is getting chemotherapy. I have to see that every time the patient is getting chemotherapy, whether we can continue with the chemotherapy or we have to hold it. So every time I see the patient, I have to reassess that. Also, I am responsible for managing the symptoms throughout. So I actually see the patients more and more frequent than a primary doctor. So I pretty much become the primary doctor of the patient, which is something that I love. Then we also have 24-hour access for like online support. For example, personally, well, for myself and my patients, they normally have my way to contact me, so that whenever they need any, for example, I don't know, maybe this was a patient that were calling me. And the other one is increased shared decision making, as I mentioned. Next slide. Next slide. Okay, so I wanted to kind of like, so the next slides are kind of like for prevention and early detection. Any questions right now about Texas Oncology and the model that we provide? No. Okay, so for the people that are here, I want to mention, who of you have either had a personal history of cancer or a family history of cancer in this room? Can raise your hand. So as you can see, cancer has touched you or your family members, and you can see it's quite prevalent, even in this small reunion. But like that's why cancer has such a big impact in our community. And one of the key elements that I want you to kind of like get from this prevention and early detection is that cancer, so cancer can be cured if it's early detected. Okay, That's where pretty much the main goal. Cancer can be cured if it's early detected. If it's early detected, yes, you're able to cure it because it's easier to remove it. It's easier to provide chemotherapy, and the cancer is not as advanced, and the cancer has not compromised the health system of the patient. Because what happens is, unfortunately, so from time to time, I have those patients who they present a very late stage, and when it's a very late stage, unfortunately, we do have a limited time window to provide treatment. And when I mean window, that's because like, if they can't, for example, this is an example of a patient I got consulted last week. The patient already came because he was having significant belly pain. He came and he was already yellow, jaundice in color. He lost so much weight, but this has been going on for like almost 8 months, and he never did anything. Sometimes there's psychological issues about it, or lack of education, or lack of like resources. But in those circumstances, it's difficult because the patient already presented, and actually, unfortunately, I wasn't able to offer much, to only go to hospice. So those are the circumstances where like, is the end of the spectrum where like, yes, the patient already presented beyond the window, I cannot treat them. However, if that patient would have presented much earlier, then I would most likely would have offered something, and maybe he will get it, maybe not cure, but at least prolong his life, especially in the advanced stage. So for most cancers, next slide. So this is a summary of like what entails to like kind of like have a preventing lifestyle activity. So basically, working on your nutrition. Okay, so nutrition is important from all aspects, from all different types of cancer. Colon cancer, breast cancer, liver cancer is very important. Physical activity is also as well that you have heard it from your primary doctors. Always do physical activity. This is one the one I want to emphasize. Cancer screenings. So why cancer screenings? Cancer screenings, it's only applicable for certain cancer only, primarily cervical cancer, breast cancer, and colon cancer, and and breast cancer. And yeah, those are, and the other one will be maybe skin cancer like melanoma. Why screening? Because the screening can detect the cancer at a very early stage again. So for colon cancer, so getting those colonoscopies, everybody who is above 45 years old should go to QPIC or to their primary doctors to get colon cancer screening. If you have a family member who was diagnosed with colon cancer, then you have to get it much earlier, the colonoscopy, to prevent the cancer. Why? Every time you go for the colonoscopy, you can detect early polyps that can later develop into cancer. So that's why screening colonoscopies are really, really important, because they can save your life from that perspective. And also they can save you from having a little pouch that eventually some patients have to end up with a little pouch, a colostomy, because the cancer was already late and they have to remove the sphincter. So the other one is cervical cancer. Cervical cancer is very prevalent in, it's correlated with socioeconomic status. So we see it in a lot of patients who are very poor. Okay, why? Because they don't really get checked. They don't go for that pap smear, and most of the time the cancer is already very advanced, and that's unfortunately not able to get cured. So cancers that are already spread, they cannot get cured. They can get treatment, but unfortunately they cannot get cured. So that's another one that is important. So if you have daughters that are in the age appropriate group for screening, let them know, daughter, go and get your pap smear, or even yourself, if you're in the screening age, go and get your screening. The other one will be for breasts. So for breast, mammograms. Also, again, breast cancer is very prevalent in the population as well, and screening mammograms are really, really important because they can detect small lesions that cannot even be palpated manually. So that's where it also takes a big role. What else? The other cancers, they don't really have, and the other one will be skin. So that means like if you are very fair skin and you have a lot of freckles, then you can go and be checked by the dermatologist to see whether it's not melanoma or a squamous cell cancer of the skin. So I will say those are the main cancers that we can screen them. The rest of the cancers, unfortunately, there are no definite guidelines for screening. So that applies for ovarian cancer. And this only applies if you don't have a familial history of cancer. So people ask me about, what about pancreatic cancer? Yes, pancreatic cancer cannot be screen. It's not like you can go to the doctor and doctor, can you screen me for pancreatic cancer? Unfortunately, we cannot do that. The only one that we applies is actually for lung cancer. Lung cancer, if you have that family member that's been smoking for like a chain smoker for many, many years, they actually can, and it's insurance approved, a low dose CT scan of the lung. And they get a low dose CT scan of the lung to assess whether there are any nodules, because these little nodules can eventually turn into cancer. So again, with the lung cancer as well, if you get it early, you're able to cure it. And then in regards to the other cancers, yes. For example, testicular cancer, you cannot screen it. Most of the time is by self-palpation. Ovarian cancer, unless you have a family history of ovarian cancer, you do like some risk genetic, for example, assessment to see whether you carry a gene. But most of the time, you cannot really screen it early. Any other questions so far? Yes. The pap smear, it depends. So we do have the pap smear, but we have now the where we check for the actual virus of the human papilloma virus. So most of the time, it starts at 21 years old for women. And that can be done through your gynecologist. Like if you like your daughters, send them to the gynecologist. Hey, you have to get your pap smear. No, mom, I don't want it yet. You have to get it. So so they don't get it. Okay, because remember the with cervical cancer, males are the ones that transmit the virus, and then the virus, most women are the ones that normally get it. And because like what happens is like they don't get checked, the virus just becomes replicating in the cervical area, and that's where and because the cancer by itself has a lot of room to grow in the cervical area and the vagina area, it just can grow and can be asymptomatic. Okay. The other one that I will say that it's important to kind of like know is for people who are, some of you may be menopausal, vaginal spotting after menopause. Like if you're noticing blood, like very tiny little blood after menopause in between the periods, then that's something to also to be checked because it can be endometrial cancer. Okay. What else? This is what I mentioned already about genetic risk evaluation. So if you remember that your mom, your aunt, your sister, they got like, I don't know, breast cancer, go and see the medical oncologist so that we can do a genetic risk evaluation and see whether you carried and inherited a gene that predisposes you to cancer, because that can change. Those cancers can be passed along to to your family members. And this is what I mentioned, this is in regards to the cervical cancer, getting the HPV vaccine, which is very effective. Okay, any next slide? Nutrition, I already emphasized about this. Primarily, nutrition is in terms of like healthy eating habits, diet. So getting like appropriate body weight, that's one. Eating more dark leafy greens, seasonal fruit and vegetables, eating whole grains, for example. That's primarily because like it's been known that, for example, constipation can increase your risk of colon cancer, for example. One of the theories is that the more the stool is like in the colon, and it's kind of like causing some like inflammation between the stool and the outer mucosa of the colon. With age and with time, that can predispose to having the colon cancer. And this is where it says also reduce consumption of red meat and avoid processed meats as well. And yes, well, we already know about this one: limited sugars, alcohol, salt, and fats in small quantities. Next. So this is again what I was talking about, early detection. Again, early detection is very important. So, for example, one thing that you can do after this meeting is like check with your parents. Like, mom, have you had a colonoscopy? Mother, have you had a mammogram? For males, it's very, especially in the I will say, for males, about the question about colonoscopy, they're like, no, I don't want anything there. So that's the main problem that they have, like a type of like a macho, like, no, I don't want anything there. But unfortunately, we have to like let them know that they're at increased risk of having cancer. And most of the time, the patients that get colon cancer is the ones that never got a colonoscopy. I mentioned this prostate cancer. Prostate cancer, it's not routine, like there is a debate because like we don't really we screen for prostate cancer, but not for everybody. So most of the time it will be a typical male patient in their 60s having urinary symptoms. So if they have like a positive prostate exam or the urinary symptoms, then we will check for prostate cancer, which you basically just check the enzyme PSA. Testicular cancer, that's pretty much for the males, are self-palpation. That's most of the time they're very easy to diagnose. Colon cancer already mentioned. Skin cancer if you're fair skin, and lung cancer, I mentioned that for patients who smoke a lot, they have the CT scan that is approved by the insurance companies. Okay. Any questions so far? No? Okay, next slide. Genetic risk evaluation is, as I mentioned, it's important primarily because of these two things. Okay, so we call this one the BRCA gene. BRCA gene is associated with, there is 1 and 2, associated with breast cancer, ovarian cancer, endometrial cancer, prostate cancer. Most of the time, patients who have breast cancer, they would call it the triple negative, they have this BRCA gene mutation. And this is inherited. That means like you got it from your dad or from your mom. And if you have it, most likely you are going to be able to pass it along to your kids as well. Lynch syndrome, it's a syndrome that increases your risk of having a lot of polyps. So you have a lot of polyps in the colon, and patients can get colon cancer at a very early age, 20s, 30s. So these patients, if they know that they have Lynch syndrome, they actually have to go for colonoscopies very frequent, like once a year, since they start like, I don't know, like 20s or 30s, depending on when the cancer started. And all of these cancers are hereditary. That means that you can pass it along. And we do have other syndromes that you can pass along, but they're different. Most of the time, yes, the medical history is where we obtain information to see whether the patient qualifies for being genetic tested. The counseling for next step, because like once you get the genetic testing, it just opens a lot of uncertainty. So it's something that has to be really discussed with the patient, whether genetic testing is in the best interest or not. Because like once you know that, then you're like, oh, should I tell my kids? The kids should know, and then the kids have to make the decision whether they have to be tested or not. So it's something that's why we have to like normally sit with the patient and discuss the risks and the benefits. This one I already mentioned about it. Next slide. Breast cancer. So in regards to the breast cancer, yeah, so 1 in 8 women will be diagnosed with breast cancer. It's very frequent. It's the #1 cause of cancer in women. Risk factors are age, diet and exercise, family history already mentioned, because like if you have your sisters or aunts with breast cancer, or a mom, that's another one. And the other one that we see it often is with women with breasts that are very dense. That means like they're like some overweight. They tend to have like larger breasts, and that turns to most of the time into breast masses. Early detection, clinical exams. I will say that the breast self-exams, we used to advocate more for like breast examination. I will say that that's most like when people are like live in rural areas where they don't have a lot of like cancer care, because they kind of go to mammograms. But most of the time right now is if you qualify for the age, then mammograms are going to be recommended. Okay, that's where most of the cancers are going to be detected very, very small. MRI screening is recommended for certain patients. And then the other one is prevention, genetic testing, alcohol moderation, and regular exercise and healthy body weight. That's the one. Next. Next. Again, so I just want to emphasize again in terms of like adjusting what. So if you're working with someone with, I will say that having cancer and working, it's not easy. Okay, I think that from the insurance perspective and from the employer perspective, it's not well designed for a patient to have cancer and work. Why? Because like patients with cancer, they have to take a lot of like leaves of absence. So they have to go to the doctor to get the chemotherapy. They have a frequent. So it's very difficult because like actually I get all these like FMLA paperworks or like leaves of absence, and it's difficult because like these papers are like they're like just very generic, and I feel that like they are not designed for patients with cancer. So sometimes we don't really know whether the patient is going to be able to work part-time or take an entire leave of absence or partial disability. So we don't really know. So what I normally ask like coworkers, if you know someone who is like touched with cancer, some of the things is like share the news with like someone that like, okay, yeah. So if that person conveyed to you that they have cancer, well, it's good to like maybe provide support. It's a very emotional and challenging disease to have, and most of my patients, for example, especially women with breast cancer, they have a hard time. Why? Because like they have work, they have like different roles in their like they have family responsibilities, so it's tough. Next slide. So these are some of the ways that if you have someone, a coworker that has cancer, ways to like help. So you can listen actively, understand their emotions, sometimes like build a plan and support system. The other day, actually, I had a patient who the boss brought her in to the clinic appointment. So which I felt that it was like a good for like a way of like supporting her. And sometimes expected and unexpected, as I mentioned, sick days, temporary leave. So it's difficult to understand someone that doesn't have cancer and someone that has cancer. They're like, oh, that coworker, she's always like maybe calling sick, and yes, maybe because like they have the chemotherapies or they got the treatment, and it's very hard because like you never know how they're gonna react on the symptoms primarily. Next slide. This one I kind of already covered. Yeah, realize, accept your own feelings, realize emotions, maybe wording. The next slide. Okay, yeah. So I think for now, it's kind of like I wanted to emphasize that. Any other questions that you may have? We can leave it open for discussion.